Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Welcome to Indications. My name is Nick Strasser. If we haven't had a chance to meet, and my co-host and friend Jan Szatkowski and I have the opportunity to chat about orthopedic cases, and we haven't done a live event for a while, but we thought we'd put together some cases to talk about things that we sometimes treat and run into. And so we are talking about non-unions today, and we put together a couple cases to talk about. How are you doing, Jan?
I'm doing great. Thanks, Nick.
Great.
Good to see you again. I had a lot of positive feedback when I returned at the OTA in Montreal about some of your podcasts that you've been doing.
Oh, good. Well, that's been fun. I mean, I couldn't do it without you, so it's been fun to do. It's been a minute since we've done it, but I think it'll be good to jump on a call again and get some more cases. And it's glad to hear that other people are enjoying it and hope maybe just it's being useful, So if you haven't joined us, we do this for reps in particular, but I think you can learn anything. Anybody in the medical field can actually learn something from what we're talking about. So today we're going to talk about non-unions. And so I put together a couple cases to chat about. So this is something that I think kind of touches things from a multiple perspective, whether it's, decision-making at time of surgery or even, what kind of bone graft, what kind of fixation to use. So we have different types of non-unions. And I just want to highlight these things because I think it's important to think about as you think about the workup and what you're treating. Jan, how do you work up for a septic non-union? I mean, obviously, a septic non-union is an infection that creates non-union, but how are you working these up?
Yeah. So thanks, Nick. So in terms of working this up, one is going to be clinical exam. Does it look infected? Is it swollen? Is it red, hot, erythematous? And then I'm getting a lot of lab work as well. You mentioned here CRP, so that's just an inflammatory marker that I get routinely, as well as an ESR. I will also get a CBC with differential. I don't find that as helpful. And then if I still not sure if it's like if there's a joint around it, like if it's periprosthetic in nature, or if it's available, I will aspirate the joint, or even the non-union site I have in the past if there's like some obvious fluid on CT and I'm concerned about infection.
Okay, what about imaging? So you talk about a CT scan. Is an MRI helpful at all?
So occasionally I do get an MRI. However, even if you get a MRI with metal suppression, I still sometimes it doesn't give me such a clear picture. But I have done it in the past, gotten an MRI or CT scan with contrast. In the CT scan, more I'm looking for if there's any abscess, associated cysts. I'm usually looking for other pathology. It doesn't really help me rule in or rule out an infection.
Yeah. And then what about TEG white blood cell scan? Is that of any benefit for these?
I tried it a few times. It's even a spec CT. I'm usually getting that if it's like something's just weird and nothing's making sense with the patient. They're still complaining of pain, and I really have no idea. I'll a lot of times add on a spec CT just to see if it gives me any added information, but it's not changed my practice.
Yeah. What about, okay, so yeah, the labs are important, and then occasionally, getting a biopsy, at times too, it can be more definitive or whatever way. A lot of times you have to make sure they're off antibiotics. Okay, so then we have pseudoarthrosis. I guess I pulled this off OrthoBullets. I think of this as like maybe the patient that has a non-union on X-ray but not super painful. Do you think that's fair, or do you think, because not all non-unions are painful. Occasionally you get like sometimes pseudofusion or pseudoarthrodesis, maybe it's a better term.
And I think you see that a lot in the foot, I would say, where, it's not fused completely one of the metatarsals, but it's not very painful. I think in the, tibia or the femur, I think that's unlikely to have a non-painful one.
Okay, then hypertrophic non-union with a lot of bone, usually indicating there's good blood supply, good biology. Would you agree with that?
Yes.
Okay. And then you have the atrophic non-union, which there's just nothing going on. And then I think of those as being inadequate blood supply. And then oligotrophic, maybe just more from inadequate reduction, maybe not much going on. It's not because there isn't biology, but because things are so far apart. Is that?
Yeah, I think that, the oligotrophic, I think is, somewhere between the atrophic and the hypertrophic. It's somewhere in between. But yeah, it's, in the hierarchy of some of the non-unions.
Okay. And then let's, real quick, talking about the different bone graft, because that's something that comes up a lot. There's a lot of commercially available options out there, but you think through the definition and thinking through these different aspects of a material. But osteoconductive, which is, has the material that acts as a structural framework. So that's like the demineralized bone matrix. And then you have the osteoinductive, which is, something that's going to, like the growth factors, it's going to stimulate bone growth. Like BMP is probably the one we think about a lot in the foot and ankle world. I think of like augment is something like that. And then the osteogenic, which is that material directly provides cells. So it's actually the cells themselves that are going to help stimulate some bone graft or bone healing in those areas. And then kind of the idea that the gold standard, or the one that we talk about the most as probably most reliable, and again with all sorts of caveats, is a generalized statement, is that of autologous bone graft. Is that how you think of these bone grafts, Jan?
Yes, and I think for different non-unions, you sometimes, or different types of non-unions, you need different types of bone grafts. So I think this is an excellent way to kind of branch them out a little bit and start thinking about them.
Okay.